This is Health Matters, a podcast from Mayo Clinic where we discuss the latest medical advice, news, and research to help you live a happier and healthier life. My name is Kristen Meinzer. I'm a writer and journalist, and this episode, we're talking about cures for cancer. Cancer is one of those words that stops conversations cold. And the fact is, it's not just a single disease, it's hundreds or perhaps even thousands of them, each with its own rules, tricks, and ways of surviving. That's a big part of why cancer is so hard to treat. At its core, cancer comes from our own cells. They're not invading bacteria or foreign viruses. They're us, gone rogue. That makes targeting cancer incredibly difficult. Dr. Bekaii-Saab is an oncologist at Mayo Clinic in Phoenix, Arizona. He specializes in gastrointestinal cancers, but his knowledge and expertise are useful in understanding cancer of all types. We'll talk all about cancer, what we can do to treat it, as well as the hope for a cure, which might be closer than you think. Dr. Tanios Bekaii-Saab, welcome to the show.
Well, thank you. It's my pleasure to be with you today.
Well, it's our pleasure to talk with you. Let's start off by digging into what exactly cancer is. Most of us know it's when we get a genetic mutation that causes harmful cells to grow uncontrollably. But how do those DNA changes happen? What's going on there?
This is a great question, and a lot of it remains, unfortunately, a mystery that we continue to unravel. Cancer is a disease where the body cells, a certain organ, they grow uncontrollably. Essentially, normal cells have mechanisms to stop growing, so when they touch each other, it's almost a signal that, hey, we can't grow up or down anymore. This is normal. But cancer just grows uncontrollably and in every direction, invades into blood vessels and spreads around. Typically, it is a genetic disorder. Now, I think a lot of people confuse genetics by thinking it is their own genetics that cause the cancer. In fact, most cancers are not linked to a genetic or an inherited genetic effect. It's an acquired genetic defect within certain cells. So all our cells are always breaking down, multiplying, and many of the cells essentially can undergo certain alterations, DNA breaks that may promote cancer. Now, the good news is that most of the times our immune system sweeps them out, takes care of them, and boom, they're gone. So there are a lot of elements that have to happen for a cancer cell to grow.
And what role do our inherited genes play in developing cancer?
There's about 10%, perhaps more, of predispositions that are inherited, meaning our cells are prone to become cancerous. But even in those patients, even in someone who may have the propensity to develop cancer, many of the patients will never develop a cancer. So we know that there are other factors. So that brings us to what is a major cause of cancer. A lot of things in our environment today. Pollution, what we breathe, what we are exposed to. So for skin cancers, for example, it's overly exposed to the sun. We're seeing an increase in younger patients with cancer. We think it links to the microbiome, to a lot of elements that folks have been exposed to growing up, foods that have been essentially tainted with antibiotics, growth hormones, and levels of inactivity that we've seen with some of our younger generation, essentially spending hours playing a game without moving, without activity. All these things appear to increase the risk of cancer, and now we're seeing it in younger folks.
You mentioned it's starting to affect younger people, so I'm curious, what role does aging play in cancer?
As we get older, our immune system is a little bit weaker. It doesn't have that sweeping power, the same sweeping power that we had when we were much younger. And so that also increases the risk of when there is a DNA break or an alteration that puts us at risk for cancer, it's less likely that our immune system is going to take care of it.
Can we dig in a little deeper to the mutations that are happening? You said that In most cases, our body just sweeps out those mutations. What are these mutations and what's happening when the body's not sweeping them out?
Something goes wrong in the genetics of the cell. So what then happens, remember our cells, most of our cells are multiplying pretty much all the time. So as they divide, those cells divide, there may be errors. And these errors essentially can lead to cancer, damage to the DNA, to the genetic material that's from the environment. There are certain chemicals, say from smoking, that essentially can increase the risk of this genetic break, this DNA break that can lead to cancer. And the more you smoke, the more you're going to be at risk. The body normally eliminates those cells with damaged DNA before they turn cancerous.
Mm-hmm.
So those are being taken care of. With age, that likelihood becomes lower and lower. That's why we continue to see cancer primarily in the older patient population. So each person's cancer has a unique combinations of genetic changes, which is one of the biggest challenges with cancer. Not every cancer looks the same. Even in the same individual, the same person, that cancer can look somewhat different from one area to the other. And then as the cancer grows, these genetic hits multiply because it's a very unstable entity. And so as the cancer grows, a lot of changes happen within the DNA, and there'll be different DNA breaks. Because it's such a disease that essentially is very diverse in its genetic composition, even in the same individual, that makes it very challenging once it starts spreading.
Got it. So does that mean that two people can both have colon cancer, but have totally different kinds of DNA changes that happened in each of them that developed into that cancer?
Yes, I mean, there are some unifying factors, but there are also a lot of factors that are very different from patient to patient. And smaller tumors are less likely to be what we call genetically diverse, meaning they tend to be very similar in composition. And so it ends up being that those cancers are much easier to control versus larger tumors that spread.
Because the larger tumors have too many diversities of mutations, and you're tackling a lot of different things all at once instead of just a few small things.
Yes.
So it sounds incredibly complicated, way more complicated in some ways than diseases caused by, let's say, a virus or bacteria, because it's a moving target at all times, is what it sounds like. Genetically, it's a moving target where it's always changing and always mutating, and it's not always going to look the same in every patient. Is that right?
Yes, absolutely. And it gets more complex as we move down the stages of cancer.
Mm-hmm.
The earlier stages, it's a little bit easier just because the heterogeneity is less. As we go through the more advanced stages, like stage 4, then, it's a much more genetically diverse cancer. What it gets even more complicated is as it continues to spread and grow, and once we treat it effectively and it becomes resistant to a treatment, that means, the clones that have overtaken now are those that are likely to be more resistant to the therapies available to us. That's why as we go not just through stages, but through phases of treatment, things get more and more and more complex and more and more difficult to control.
Mm-hmm. And is cancer going to pose different challenges when it's in different parts of the body? For example, if I have a GI cancer, is that going to be harder or easier to treat than, let's say, a cancer in a different part of the body?
Absolutely. And that's why we have a large area of specialization in cancer. So not everyone can treat, not every oncologist, at least at Mayo Clinic, not every oncologist treats all cancers. Most oncologists treat only one specific type of cancer because it's very different depending on where it starts. And then, the specific types of cells also complicate matters. So you have the carcinoma, you have the sarcoma, you have the leukemia, you have the lymphoma, multiple myeloma, and it can go down and down and down. Carcinomas are the most common cancer cells or forms of types of cancer. They're formed typically from what we call epithelial cells, which are essentially cells that are outside and inside the body. So the skin is epithelium. The inside of the colon is epithelial. Those would be carcinomas. Sarcomas, typically start in the bones or the muscles. Now, oftentimes I hear folks asking, well, if I have colon cancer that went to the bone, is that bone cancer? No, it's colon cancer that spread to the bone. Cancer that starts in the bone is a sarcoma.
Got it. Now that we have some definitions down, let's talk a little bit more about the types of cancer your practice focuses on. That would be carcinomas. How does a carcinoma in one part of the body differ from one in another part? Are there different treatments based on where the tumors are?
Carcinomas by themselves can start, let's say, in a colon or in pancreas. They behave differently, whether they start in the pancreas or start in the colon. Even when we find targets within those cells, meaning genetic targets that are very similar, they respond differentially. Why is that? Because although they're carcinomas and although they may have a genetic alteration that's very similar in both, there are a lot of other factors within those cancer cells that make them very different in terms of how well they respond to treatment. Even the same treatment can apply to both and they respond differentially. So yes, it matters where the cancer cell starts. So what organ, what type? I mean, there are more than 100 types of cancer, more than 100. So imagine that. And they're very different, and that by itself just adds a level of complexity. Now, when I say 100 types of cancer, that's just accounting for organ and tissue. When we start digging deep into the genetic material of the cancer, we're talking about thousands of cancers.
Cancer happens when something goes wrong in a cell's genes, causing the cells to divide uncontrollably. These abnormal cells can form tumors, which can sometimes spread to other parts of the body. There are over 100 different types of cancer, and where it starts in the body matters. Your genetics do play a role in cancer risk, but outside factors usually have a bigger impact. Things like smoking, sun exposure, diet, and environmental toxins. Lately, more young people have been getting cancer, especially gastrointestinal types. This trend is likely tied to modern lifestyles, including what we eat, how active we are, and other habits. When it comes to treatment, it has to be aggressive enough to kill cancer cells, but precise enough to spare healthy ones, a balance that medicine has been chasing for decades. All the while, tumors can mutate, adapt, and even learn how to resist drugs that once helped. Add to that the fact that no two cancers are exactly alike, not between patients, not even within the same tumor, and you start to see the scale of the challenge of finding the right treatment. We'll talk about that next. Let's dig a little deeper into treatment. And before we do that, can you just clarify, is there a cure for any type of cancer, or is it all just considered treatment with the hope of remission?
That's a great question. Is there a cure for cancer? And the answer is depends. For the earliest stages of cancer, the answer is yes, there's a cure. So let's take colon cancer. Colon cancer presenting with a small tumor in the colon, localized, removed, many times not even a need for chemotherapy. The patient is 90% likely to be cured from their cancer.
Wow.
Take a stage 3 colon cancer, which now is deeper and has more lymph nodes involved. With surgery, we cure about half of the patients, and that's a cure. When we add chemotherapy, we add to the cure about 20-25%, depends. So that brings, almost 3/4 of the patients to be cured. Stage 4 colon cancer is seldom curable. Now, I say seldom, it's not zero. So that's the good news, is now we're curing more of these patients, as long as they have very limited disease confined to one organ, whether it's in the lungs only or in the liver only. If we can remove it surgically, then we can still cure about 20-30% of the patients. Now, unfortunately, that's only 5% of all patients with stage 4. Now, I'm going to add another level of complexity to this discussion, is with patients who have a driver in their colon cancer that makes them very visible to the immune system. Today's immune therapy can cure more than half of those patients, even if they have very advanced stage 4 cancer. That's a small number of patients, but that tells us something. That tells us that as we continue developing research tools, as we continue to expand our capacity to target cancer at its core, but also take care of the immune system around it, put together, that tells me that we will likely be able to cure cancer at any stage in probably the next decade.
Wow.
I think we're going to get to the point where most cancers will be curable, and we're going to get ultimately to the point where all cancers will be curable, but it's going to take time.
Wow. And the idea that in the next decade or so, we could be curing so many more cancers or possibly all of them, that's mind-blowing for me, and I'm sure for a lot of our listeners right now, and really hopeful. That's great. But in the meantime, we have to talk about what's happening right now in the current state of medicine with cancer. Let's talk about the treatments that are currently being practiced. Let's start with the most invasive, surgery. What procedures are used as far as surgery is concerned? How effective is surgery?
So it depends on the stage of the cancer. Surgery has a role. The good news is that surgery is becoming less and less invasive. We've moved from talking about colon cancer, but we can talk about others as well. You can pretty much open the whole abdomen, expose all the organs, close back up. It's pretty tough surgery. We've gotten to the point now where many patients actually can have part of their colon out with a robot, so robotic assisted surgery. Just have like 4 or 5 little holes in the belly, tiny. They do the same for prostate. They do the same for upper rectal cancers. They do the same now for pancreas, for parts of the liver. So we do robotic surgeries across the board. Now, of course, at the end of the day, most surgeries are very invasive, but necessary.
And are they effective?
And they are very effective in the earlier stages of the cancer, yes. I will tell you, though, that with time and with a lot of the improvements in the way we target cancer, we're going to see less and less and less need for these more invasive modalities. But that's not today. It is today for few patients, but that little piece of the pie is going to continue to grow.
That is amazing. What about chemotherapy? What form does that take exactly? An IV drip, a pill?
Chemotherapy can be all these. Can be IV, can be oral, can be injection in the muscle or in the subcutaneous tissue, meaning the fat, or it can be topical. For some skin cancers, we give 5-FU topically as a cream. But most chemotherapies today are actually given intravenously. So traditional chemotherapy, at least, is essentially chemicals. It's chemical therapy that essentially is meant to stop the growth of cancer cells.
Let's talk about radiation therapy. How does that work?
So radiation uses high energy rays directed at the tumor from outside the body, essentially breaking the DNA of the cancer cells. So it stops them from dividing and growing. So what that high energy does, essentially, it creates what we call these free radicals, which are very toxic to the DNA. And so they will lead to what we call cancer cell death. So they kill cancer in those areas. And there is another form of radiation called internal radiation or brachytherapy that's implanting radioactive substances inside or near the tumor. There's also radionuclide therapy, which essentially is targeting liver tumors in my practice with essentially radiation beads that are implanted into the area and they radiate just locally. Radiation's benefit is primarily when the tumor is contained. Most times it actually complements surgery, or we use it for one more purpose, and that's called palliative radiation. That means if someone has a cancer that has spread to the bones, and the cancer in the bone is causing a lot of pain, and chemotherapy is not helping quickly enough, we can radiate the area in the bone to help with the pain. So that's the palliative application.
Okay. Something you mentioned earlier that I'm curious about is immunotherapy. How exactly does immunotherapy work? It sounds like it's from the future.
It is. Well, the future is now. Here's the good news. However,
Yes.
we're only scratching the surface. We've seen essentially significant improvements depending on the cancer, but we haven't been able to expand those to most cancers. When we think about immune therapy, we think it's a therapy like a vaccine that's going to help my system, see the cancer, attack the cancer. Well, it's not that simple. And the reason why it's not that simple is because the environment around the cancer is very immunosuppressive. Take the example of rheumatoid arthritis, an autoimmune disease. Typically, everywhere in our system, the immune system is very balanced. Now, there's an imbalance where essentially the immune system is aggressive and literally attacking your joints and causing inflammation and damage. So you lose the balance that's typically present in our system that makes sure that the immune system doesn't get too angry that it starts attacking its normal organs. On the other hand, you can't also allow the suppressor element of our immune system to go too strong, because then you can't fight any disease. So it's a balancing act. And how do you keep that balance is important.
So how do immunotherapies help keep that balance?
Cancer is an immune suppressive disease, meaning that what it does, it invites the bad cells in and it gets rid of the good cells out. If you think about a cancer cell sitting here and then an immune cell sitting here, that immune cell is close, but it's not attacking the cancer cell because there's a link between the two. It's almost like a bear hug, right? So you can't really release yourself so you can attack. And so what immune therapies today that we have most commonly used are the checkpoint inhibitors. These checkpoint inhibitors essentially uncouple those cells. They essentially help those T cells, those beneficial immune cells. And so that cell now says, okay, now I see you, and boom, attacks. Now, unfortunately, they only work in a small number of patients. They don't work in all patients. And the reason for this, because there are a lot of other bad actors and good actors that need to be in, and that balance need to be there. You have to control the bad. You have to inflame the good. The point of this is there are the bad guys, the good guys, and there are the guys who really want to work with the good guys. And you got the guys who want to work with the bad guys. And so just working with the good guy is not enough.
There are a few different ways to treat cancer, and which one you go with depends on how advanced it is. When cancer is caught early and the tumor is small and hasn't spread, surgery is often a big part of treatment. In some cases, it can even completely cure it. Radiation therapy is often used alongside surgery. It uses high-energy rays to kill cancer cells or slow their growth. There are different types of radiation treatments, from the standard external beams to tiny radioactive beads that are placed near a tumor. Chemotherapy is another common option that can come in the form of a cream, a pill, or an injection, though it's most often given through an IV. The newest type of cancer treatment is immunotherapy. This approach helps the immune system recognize and fight cancer cells more effectively. It's a complex field, but it's also one of the most promising areas of cancer research, with the potential to work across many cancer types and stages. That's what we'll dive into next. So let's talk about the future of treating various cancers, focusing on GI cancers. So what does the future of GI cancer cures look like, and how far are we from the goal of those cures?
I think that the future is very bright. We're doing strides every day. For the last 25 years, I've seen a significant shift in how well we're doing, from immune therapies getting into these targeted therapies that specifically attack genetic aberrations that drive cancer. We're seeing a lot of growth in all these areas. Now we're learning more and more about not just what drives cancer, but also what drives resistance to the cancer treatment. So when I gave someone a targeted therapy, thinking that, okay, I'm targeting this one particular gene, and I do it, and I'm seeing a good response. Great. And then for some patients, I'm not seeing a response at all. For other patients, that response is short-lived. For few patients, the response can be years. So why the difference between those three, although the gene is the same? And so here we're starting to learn about what is driving the resistance to these treatments. And as we learn more and more about those, we're creating more and more therapies that essentially address those emerging alterations.
Now, what role do prevention and screening play in our quest to cure cancer?
The best way to cure cancer is to prevent it. One, to essentially catch it really, really early. And for that, screening makes a lot of sense. Most cancers today, we don't have a screening tool for them. Now, we know for breast cancer, mammogram can help. It's not 100%. Colon cancer, rectal cancer, colonoscopy will help a lot of patients. Not everyone, but think about it. If your odds are a 50-50, I'd take these odds. If you go to Vegas with a 50-50 odds, you're gonna hit a lottery, right? So I'd do this with even less than that. But the point of this is that screening can catch a cancer early. So colonoscopies established, mammograms established. For patients who are smokers, low dose CT scanning of the chest can prevent a lot of these cancers, prostate, PSA. So we have certain cancers, and these are the four most common cancers that are essentially screened for, and preventable depends on how you think about prevention. So for colon cancer, for example, removing a high-risk polyp is prevention. The tragedy, though, I will tell you, if you look at just colonoscopies, if you look at the screening, only half of the patients actually undergo screening for colonoscopy. Half don't. And it's not just an access issue, because it's not unique to the US. It's also in Canada and other parts of the world.
Yeah, there's 100% free healthcare in a lot of other countries.
And yet it's the same problem. It's the same problem because there are some cultural issues. A lot of people just don't want to do this. They don't like it. They don't want to do it. They feel it's too invasive. So we have non-invasive forms developed by Mayo Clinic initially. Cologuard is one, but there are others as well. I can tell you, colonoscopy, the worst part is actually the prep, which is much, much better with time. But the colonoscopy itself, you won't even remember it.
Yeah. I mean, I've had one. I thought it was great. I was like, that was snappy.
I've certainly had mine. And the prep was a bit of a, I told my wife and I said, man, I feel the lightest I've ever felt. This is actually great.
Drinking a lot of liquid, spending some time on the toilet, and then I'll say for myself, I felt very tidy afterward.
I felt the same. For sure. But the point is that it actually is an intervention that can prevent and screen at the same time.
I understand the recommended age for colonoscopies has come down from 50 to 45. Why is that?
Because we're seeing a lot of younger patients, and I suspect it may continue to go lower. When you see 20% of your patients with colon cancer now under the normal age risk, and because we continue to see the rise in younger patients, it's likely at some point we'll get to 40.
How about the future for screening specifically? Is there anything on the horizon that'll help us detect cancer earlier or perhaps detect it more easily?
There are tools that are coming. They're not there yet, but they're coming. The DNA in the blood that we capture in the later stages of the cancer, that essentially informs us about treatment options, or even can assess, whether there are any cancer cells left behind after surgery. These are being now applied with very high sensitivity tools to screen for cancer from a blood test. But at this point of time, I can't recommend it for everyone, at least. So today, I would say that, this is out there, this is coming. Some of them are commercially available, but they have to be very, very judiciously used, and they should not replace our traditional screening methods, at least for now. Is there a future where everyone will get a blood test and will be able to figure out whether they're going to develop cancer or not, or any other disease, by the way, not just cancer. The answer is likely. It's going to be a very different world in 10 years from now.
It's fantastic. So great to hear. Dr. Bekaii-Saab, thank you so much. This has been so great.
Well, it's been my pleasure, and thank you for having me.
More than 600,000 Americans die from cancer every year, but that number is likely to go down as we get better at finding and treating it earlier. Cancer is an incredibly complex disease. Treating it and curing it is a huge effort. Scientists around the world are working on it, including researchers here at Mayo, many of whom are focused on developing new immunotherapies, which are leading the way in cancer treatment. And there's real reason for hope. If Dr. Bekaii-Saab is right and research keeps moving at this pace, we could be much closer to solving cancer than we ever thought. It could even happen within the next decade. Okay, that's all for this episode, but if you've got a question or topic suggestion, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. For more Health Matters episodes and resources, head to mayoclinic.org/healthmatters. And if you found this show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, take care and stay healthy.